Hey, future PTAs. I hope everybody's doing well. Today we'll talk about movement and motor neurons. So our outline, we'll talk about motor neurons, muscle tone, control of movement, motor planning, and some different tracts that help you move from the spinal cord to the brain. Motor neurons are nerve cells that cause muscle contractions. There are three types of muscle tissues. So there is skeletal muscle, which is in the muscles that help you move your arms and legs, the voluntary muscles of the body, and they are made of myocytes. There are cardiac muscle tissues that are in the heart muscle, and then there's smooth muscle tissues, which are throughout the organs. Both the cardiac and the smooth muscle are regulated by the autonomic nervous system. Lower motor neurons, these are neurons that are throughout the body, so they're not in the brain and spinal cord, but more of like the peripheral nerves are called lower motor neurons. They innervate and synapse directly on skeletal muscles. The cell bodies are located within the brain and spinal cord, but then the axons form part of the spinal nerves and the cranial nerves. Peripheral nerves enter the muscle belly at the motor point, and then they divide into branches, and then they end in an axon terminal where it synapses on one skeletal muscle fiber. So the picture is just showing you that neuromuscular junction, the synapse between the lower motor neuron and a muscle fiber. Each neuromuscular junction is enclosed with connective tissue to protect and separate it from surrounding tissues. And then when a lower motor neuron is injured, the muscle cannot activate. And so you would have weakness, and eventually the muscle will become atrophied. The only way you can activate that muscle if the neuron is not intact, if it's damaged, is if you use external stimulation, like a neuromuscular electrical stimulation machine. But internally, the person can't just with their brain cause that muscle to activate and move the body part. Muscle contraction. So at the neuromuscular junction, each axon terminal releases a neurotransmitter, acetylcholine. The motor end plate is the cell membrane at the neuromuscular junction, and contains those receptors for the acetylcholine. Once that acetylcholine is released, it binds to the receptors, and then it allows sodium to flow into the muscle to depolarize the cell and then cause that muscle contraction. Calcium ions are released from the sarcoplasmic reticulum, and then that muscle contraction starts. So there's a whole chain of reactions of the cell depolarizing and causing a muscle contraction. And the contraction causes the fibers to become closer together and shortened. When the muscles relax after contraction, the calcium is pumped back into the sarcoplasmic reticulum. The acetylcholine has to be removed from the receptors to stop that muscle contraction. And then acetylcholine esterase is an enzyme that breaks down the acetylcholine to free up the receptors so they can bind to acetylcholine again and have another muscle contraction. So it is like, a cleanup crew after the muscle contracts, then this cleanup crew has to come and set everything back up for another contraction before you can do a second muscle contraction. So this is going on behind the scenes every time we contract our muscles. Lower motor neurons and muscle contractions. So they must stimulate a muscle cell to cause a contraction. They must be inhibited to allow the muscle to relax. All other parts of the nervous system must go through the lower motor neuron to reach a muscle cell. So the lower motor neuron is sometimes called the final common pathway. If the lower motor neuron is damaged and enough muscle cells lose their motor neurons, then the muscle will be denervated. We call it denervated. And so it becomes weak or paralyzed. It cannot move. The lower motor neuron is the only way to reach a muscle to cause that contraction. One disease process that can affect the lower motor neurons is polio. So, polio is a disease caused by a virus that destroys lower motor neuron cell bodies. If enough of those cell bodies are affected, then if few enough, sorry, are affected, then surrounding lower motor neurons can actually re-innervate by producing these collateral sprouts, so they can like sprout out and activate other motor, other muscle fibers that they weren't attached to originally. But if too many are destroyed, then there's more weakness, there's more paralysis left in that area. Even if initially the person has some weakness, but then they're able to regain function, eventually down the line, oftentimes they'll have what we call post-polio syndrome, where they get fatigued easily, where they have weakness and atrophy years later, because those lower motor neurons like wear out. It's like they become weak over time. One lower motor neuron and all the muscle fibers it innervates make up a motor unit. So muscles with small motor units can be controlled with more precision like your eye muscles. And then muscles with larger motor units generate stronger contractions. They contract and maintain your posture. They are muscles like your quads that cause big, large, strong movements. The more motor units that are recruited, the more force of a contraction, and then the smaller motor units are recruited first before larger motor units are gradually recruited. So the smaller motor units can range from like one lower motor neuron to only 20 muscle fibers, and larger ones, one lower motor neuron may actually innervate 2,000 muscle fibers. So there's a big range. The size principle, so when we activate our muscles, there's a gradual development and control of muscle tension. So we don't just go from nothing to all, because if we did that every time, then we would have all these, spastic, jerky movements and wouldn't be able to control that movement and make it smooth. So we gradually recruit larger and larger motor units. So when we are with our brain using the lower motor neurons to simulate a muscle contraction, it goes from the smallest motor units to the largest. But when we use like an electrical e-stim machine to mechanically stimulate a motor contraction or a muscle contraction from the outside, it actually goes from the largest motor units to the smallest. So the opposite of what our body does, which is one reason why if somebody's doing like Russian stim or neuromuscular e-stim, you have them contract while the machine is contracting, so that the machine is getting the larger motor units and the brain is getting the smaller, and then you get a full contraction from both ends. Upper motor neurons, these connect the brain to the lower motor neurons. So these are throughout the brain and the spinal cord. Cell bodies of the upper motor neurons are located in the cerebral cortex and in the brain stem. The upper motor neurons control the cerebellum, the basal ganglia, the supplementary motor areas, all those areas. The cortical upper motor neuron cell bodies are in the frontal lobe. 60% of them are in the primary motor cortex. The remaining 40% are in the premotor cortex, supplementary motor cortex, and the primary somatosensory cortex on the post-central gyrus. So all of them are, kind of in the same portion of your brain together. The cortical upper motor neuron cell bodies are in the oh, sorry, I just said that. They're organized into a motor homunculus, which we've talked about before, where different motor neuron, so sensory is the same way, where a lot of your sensations from your hand all travel to the same part of your brain. So same thing for motor. All of the um, brain areas devoted to moving the hand are all located in one area, and the body areas that need to have more precise movements, like the tongue or the hand, actually take up larger amounts of space in the brain than like maybe your trunk that doesn't have to have such precise movements. This is known as proportional representation. We can actually increase or decrease the amount of representation that our body part gets in our brain. So, like somebody who plays the guitar from an early age and uses the fine motor dexterity of their hands a lot and really focuses on that can increase the amount of brain dedicated to their hand movements. Or somebody that has a leg amputated and is no longer using that body part because it's gone, then that portion of the brain will actually shrink and decrease the amount devoted to that. ALS or amyotrophic lateral sclerosis, which is also called Lou Gehrig's disease, is a disease that affects both the upper motor neurons and the lower motor neurons. They don't know exactly what causes the disease, and unfortunately, there's no cure. But the patient presents with it's a progressive weakness that causes both flaccid and spastic paralysis. So not only do they have weakness where parts of their body are just hanging flaccid and paralyzed, but other parts are spastic and in those patterns, those synergy patterns that we see after a stroke or after certain brain injuries. Um, Eventually, this disease progresses and can attack the muscles that allow you to breathe. And so, unless the person is put on a ventilator, then it will become fatal by attacking those muscles. Um, and there's no cure. So it's a very sad and mysterious disease. Descending tracts. So now we're going to talk about the different tracts in the spinal cord. So upper motor neurons um, form tracts or bundles of neurons that travel together in the white matter of the brainstem and spinal cord. Remember, the white matter is white because it's those axons surrounded by the myelin sheath. And so axons travel from a cell body and out to an area. The corticospinal tract connects the brain to the lower motor neurons in the spinal cord. It crosses in the brainstem. The right motor cortex controls the left side of the body. Then the corticobulbar tract connects the brain to the lower motor neurons in the cranial nerves. So most are bilateral and control muscles on both sides of the body. Together, these two tracts control all the voluntary movements of the body, including speech, including facial expression. All of these are controlled by one of these two tracts. The corticospinal tracts are also called pyramidal tracts. And the facial nerve is actually the only cranial nerve without bilateral upper motor neuron innervation. So all other cranial nerves have innervation to both sides of the body, but the facial nerve doesn't. Sometimes damage to one facial nerve will cause loss of facial expressions on that side of the face. However, sometimes there are other tracts in the brain, like the ones summon the anterior cingulate gyrus that originate in like the emotional areas of the brain that allow us uh, to express our emotions, that sometimes those can actually take over and allow us to still have facial expressions, even though the tract that causes muscle activation of the face is completely paralyzed. So that's a really interesting phenomenon that sometimes can happen when the facial nerve is damaged. Corticospinal tract, the corticospinal axons divide into two tracts within the brainstem. So one tract, which composes like 90% of it, switches to the opposite side of the body and forms the lateral corticospinal tract. This is the largest tract within the spinal cord, and it is almost always affected if somebody has a spinal cord injury. Almost always, this lateral corticospinal tract is affected. The remaining 10% of this corticospinal tract stays on the same side and forms the anterior corticospinal tract. This synapses on lower motor neurons, innervating muscles of the neck, trunk, and proximal upper extremities. This tract descends to the thoracic level of the spinal cord and no further. So that's why it only innervates the neck, the trunk, and the the proximal arms, but doesn't innervate anything in the legs. Interneurons, so these are small nerve cells in the spinal cord. They connect neurons into a network or into circuits. Most direct connections of the lateral corticospinal tract onto the lower motor neuron interneurons control distal limb movements and independent movements of fingers and joints. Indirect connections synapse into interneurons that activate or inhibit interneurons, and they influence your reflex activity. They control complex movement patterns that are hardwired into the spinal cord. So, like your muscle memory, like being able to ride a bike, you're not thinking about it anymore. If you've been doing it for years, your mind can be somewhere totally different because your muscles know exactly how to do it, and that is in these tracts of the body. So upper motor neurons in the lateral corticospinal tract synapse directly onto the lower motor neurons in the ventral horn of the spinal cord, and these form synapses within the interneurons in the gray matter of the brain, or sorry, so of the spinal cord. Extrapyramidal tracts, they originate in four brainstem nuclei: the reticular formation, the vestibular nuclei, the superior colliculus, and the red nucleus. And these are all responsible for controlling movement of the trunk, of the proximal extremities. They help with postural reflexes, and they help you maintain and modify muscle control. Reticulospinal tracts, they originate in the brainstem and the reticular formation. They control muscles involved in posture and in gait, and they help you modify your muscle tone. Damage to this area does cause spasticity, so that increased tone where you're stuck in certain movement patterns. The vestibulospinal tract, it arises from the vestibular nucleus, innervates the neck, the trunk, the proximal limb extensor muscles for maintaining your balance. Vestibular is always pretty much talking about balance. They also help control the cranial nerves that innervate your eye muscles. So that's one reason that your eye muscles so greatly affect your balance, or your sight is so tied in with your balance, and it helps maintain focus while your head is moving. The tectospinal tract is made of upper motor neurons from the superior colliculus, or the tectum, and it controls muscles that are responsible for reflex movements of the neck. So it helps link the visual system with the neck muscles to allow you to track and follow an object that's moving. The rubrospinal tract also originates in the midbrain red nucleus, but it plays just a small role in humans. It doesn't play a big role in our movements. Motor neuron lesions. So some conditions target motor neurons, such as like polio or ALS. Some affect motor neurons rather than target them, such as brain injury, stroke, spinal cord injury. Lower motor neurons injuries result in hypotonia. And so Okay, so I think the first statement, I just did not, I left a word out. So some conditions target the lower motor neurons. Polio is lower, ALS is lower and upper, and then some affect upper motor neurons. So I left a word out in both of those. I'm sorry about that. The brain injury, the stroke, spinal cord injury all affect upper motor neurons. But with lower motor neuron injuries, you have low tone, you have low reflexes. The skeletal muscle becomes weak and atrophied and likely paralyzed. With upper motor neuron injuries, there may still be weakness, they may still be paralysis, but they're more likely to have hypertonia and hyperreflexia. So that's spasticity and increased tone. And then turn it on. No. What do you mean? Um, and they typically will lose that voluntary movement. So the ability to move then when they want to, with those upper motor neuron lesions. If the upper motor neurons are damaged but the lower are intact, then the patient could have some type of reflex muscle contraction. So sometimes that'll happen like with a spinal cord injury, the upper motor neuron is damaged, and let's say they've lost bowel or bladder function. But if the lower motor neuron is still intact, they may be able to stimulate a reflexive bowel movement so that they're able to still empty their bowels without, having to have like a colostomy bag or something like that because the lower motor neuron is still intact and can still be stimulated with a reflex. These are the Asia key muscles by level of injury. So what this means is like for the first one at the level C5, if somebody has a C5 spinal cord injury, then basically all the muscles listed below that level will all be paralyzed or weak, depending on if it's a complete or incomplete injury or lesion. But the key muscles that they have access to would be the elbow flexors. So if they have a C5 injury, the good news is they can still actively flex their elbows on their own and then use that for mobility. So it's kind of what muscle groups they still have available to use so that you can help figure out what type of functional movement they have. So C7 is really important because that's elbow extensors. So in order to do like a wheelchair push-up, in order to do like pressure relief so that they don't get pressure sores on their butt, that's a really important one. If you want to do a sliding board transfer, the elbow extensors is really important for that. That's huge in independent mobility when they're able to extend their elbows and push themselves off of a surface to move. So these are the key muscles that are available if with somebody who has an injury at that level. So they still have access to these muscles. So let's say like L2 hip flexors. Yes, they have access to the hip flexors, but then they also have access or use of all the muscles listed above it. So basically, their arms aren't affected once it's at L2 because it's too low. But most of the muscles in their legs are. Only their hip flexors are really available as far as leg muscles. Okay. So if you have questions on how to use this chart, let me know because I do want you to memorize it. This is really important to know and to understand in helping somebody regain functional mobility. And it's also important when you take the boards exam. So I'm not going to read it all to you, but do make some flashcards and memorize this slide. Same with this. These are key sensory dermatomes. So these are key areas that where they have sensation. So like at the nipples, if they have sensation there, then that is tied to level T4 in the spinal cord. The belly button is to level T10. So if you look at these dermatomes, then that is the area that area, if you were to rub that area, depending on where you're rubbing, then it tells you what nerve roots are responsible for the sensory information coming from that area. And so then that helps you also uh, understand and diagnose. We don't usually, definitely PTAs don't diagnose spinal cord injuries. Typically, by the time they get to a PT, a medical physician has done all the workup and given us a true diagnosis. Um, but this is one of the ways that they look. They look at what levels is sensation available and what muscles do they have use of and how strong are the muscles. Is there weakness or paralysis? And that's how they determine what level the spinal cord injury was at. All right, muscle tone. This is the amount of resistance a muscle has to passive stretching. So there's a mechanical component of muscle tone, which comes from physical properties of muscle cells and connective tissue coverings. There's a neural component to muscle tone, which is produced by motor neurons that innervate each muscle fiber. And then there's a small number of motor units that are always on, which produces a little tension in your muscles at rest. That's why they're not just completely flaccid whenever you relax. Um, so even when relaxed, all skeletal muscles that have intact nerve innervation have some type of tone to them. So if they have no nerve innervation, then you'll feel it flaccid and it will feel different than a resting muscle that has some nerve innervation. Gamma loop, this is the neural component that can be modified by the environment or emotional factors. So, for example, your muscle tone increases when it's cold or when you're anxious, if you're scared. And on the opposite side, your muscle tone can decrease when it's warm, you're in a warm environment with massage or with relaxation of the brain and of the body. So these are things to consider whenever you're helping somebody who has high muscle tone relax or somebody who's kind of weak gain some muscle tone. The gamma loop reflex is responsible for adjusting that muscle tone to meet the environmental demands. Increased stimulation of the gamma loop increases the tone, and decreased stimulation of the gamma loop decreases the tone. Disruption of this loop, such as like lower motor neuron damage, can decrease your tone. But damage to the upper motor neuron can cause overactivity of this gamma loop, which increases tone. So this kind of explains why people with lower motor neuron damage are more flaccid, and people with upper motor neuron damage are more spastic, have more spasticity. This loop is controlled by the brain through these descending tracts in the spinal cord. Specifically, the dorsal reticulospinal tract is one of the primary ones that controls it. Muscles with decreased tone, again, feel flabby, soft, don't have a lot of resistance. And those with high tone feel rigid, stiff, tight, hard to stretch. The alpha motor neurons are also become more sensitive with upper motor neuron damage. They're more likely to depolarize to produce an action potential. Control of movement. So upper motor neurons innervate your lower motor neurons, and those innervate your muscles. So that's kind of the pathway from upper to lower to muscles. Normal motion requires your coordination, initiation, inhibition, timing, and all of that to work together at the right time to coordinate those movements. If any portion of the brain that controls these functions is damaged, then movement will start to appear abnormal. The cerebellum, there's two hemispheres of the cerebellum, and they are connected by the vermis. They connected to the brain by axon bundles, which are called cerebellar peduncles. And they are covered with granular cells and Purkinje cells that increase the synaptic contact. The primary function of the cerebellum is coordination. Also, it helps with balance and motor control. Uncoordinated movements are called ataxia. That's uncoordinated movements. And then the cerebellum also has a connection to language, to association, and to limbic regions of the brain. Remember, limbic system controls your emotions. The cerebellar nuclei are the dentate, the vestigial, I'm probably pronouncing some of these wrong, the globose, and emboliform. Damage to these causes ipsilateral ataxia. So damage to one side of the cerebellum or that cerebellar nuclei can cause uncoordinated movements on that same side of the body. So some other issues that you would have if you did have cerebellum damage are difficulty planning, doing motor planning, goal setting, abstract reasoning, your working memory, disinhibition of the frontal lobe, disinhibition, which is similar to frontal lobe damage, where you're not able to like stop yourself from, blurting something out or from doing a task that comes to mind. That's thought to be related with the cerebellum and with other areas of the brain. And this kind of can help explain why people with cerebellar injuries also have some unexplained cognitive deficits that appear. All right, cerebellar functional areas. So the vestibulocerebellum coordinates balance. The spinocerebellum helps with posture and gait. And the cerebrocerebellum coordinates distal limb movements and small muscles used for speech. Vestibulocerebellum receives input from the vestibular apparatus about the position of your head in space. This affects muscle tone throughout the body, helps you stay upright and have a horizontal head position so that things aren't all, looking sideways and leaning. Damage to this area can cause disequilibrium or a loss of balance, difficulty maintaining and correcting balance. So some of the symptoms, if the vestibulocerebellar tract is damaged, include postural tremors. I'm sorry. Which are like large amplitude back and forth movements while you're standing. We usually use these to maintain our balance when we're standing on a moving surface, but this is happening at rest when those movements aren't needed. Um, Truncal ataxia is very similar, large amplitude trunk movements to maintain balance, and they're happening again when that is not necessary. The spinocerebellum is formed by the vermis, parts of the cerebellar hemisphere. It receives input from your proprioceptors and helps coordinate those proximal limb movements, connects the lower motor neurons indirectly through the vestibular nucleus, the reticular formation, and the brain. It also has connections to the primary motor cortex. The cerebrocerebellum is in the lateral 2/3 of each cerebral hemisphere. It regulates your force, your timing, and your direction of movement. It's also known as the cordocerebellum or neocerebellum, and it helps your motions to be smooth, rapid, precise, helps you detect and correct your errors. This is essential for accuracy, adaptability, and coordination of complex movements. It's also necessary for motor learning, for nonverbal communication, and the ability to shift your focus and attention. So it actually receives input from and sends signals back to the primary motor cortex, the cortical association areas of all four lobes. So it creates like a circuit involved in motor learning and cognition and timing, sequencing, velocity of movement. So it kind of helps kind of bring a lot of those movement tracks together to kind of make sense of all of it. So if this is damaged, you can imagine how uncoordinated and disassociated some of the movements become. Cerebrocerebellar damage. Injury results in ataxia of vocal and distal limb muscles. It affects muscles on the same side that are damaged. Some of the symptoms are asynergia, which is a lack of coordination between muscles that usually work together. Dysdiadokinesia, which is difficulty doing the rapid alternating movements. So this is one way that we usually check for dysdiadochokinesia, see if they can do the hand flapping. Ataxia, which is your inability to coordinate muscles for voluntary movement. It can also cause dysmetria, which is like overshooting or undershooting when you're reaching for objects, just doing it in kind of an uncoordinated way. It can cause intention tremors and slurred speech. The basal ganglia, I have decided to shorten it to BG, even though that's not really a common abbreviation we use. It's just shorter for my slides. So BG here is referring to the basal ganglia. So this is a group of interconnected structures. They are located deep within the cerebellar hemisphere, and they are involved in initiation, inhibition of movement, and initiation of thoughts and emotions. The basal ganglia help direct the actions of motor tracts and therefore all voluntary skeletal muscles in the body. Consists of the caudate nucleus, the putamen, the global pallidus, and it's called the kinetic system because of its role in generating and regulating movements. The striate cortex is made of the caudate nucleus and the putamen. That it has a striped appearance, and then the lenticular nucleus is made up of the putamen and the global pallidus because it has a lens shape. It's called lenticular. You don't have to memorize either of those things. That's just kind of a fun fact. Nuclei within the basal ganglia, there's a substantia nigra, which is in the midbrain, the subthalamic nucleus, pedunculopontine nucleus, and then the ventral tegmental area, or VTA, which is involved in addiction and pleasure-seeking behaviors. Some of the circuits in the basal ganglia, there's the motor circuit, which is involved in movement initiation. I'll go into that more in a minute. The cognitive circuit, which connects the prefrontal cortex and the cortical association areas. The limbic circuit, which connects with our emotional centers. The oculomotor circuit, which regulates eye movements. And then all of these either increase the cortical neurons to affect thoughts, emotions, and movement, or they decrease those neurons. So they do affect thoughts, emotions, and movements. That motor circuit I was talking about has a direct and an indirect pathway. The direct increases stimulation of the motor cortex and initiates movements. It helps with distal muscle movements and it inhibits proximal muscle movements. The indirect pathway decreases the stimulation of motor cortex so that it decreases movement initiation. So it stimulates proximal movement muscles and inhibits distal ones. So the direct pathway helps with your distal muscle movements, and then the indirect helps with your proximal muscle movements. These pathways have to be balanced for normal movement to occur. So if one is overactive and one is underactive, then it's going to inhibit certain movements and keep you from having normalized movement patterns. The substantia nigra, this produces neurotransmitters, the neurotransmitter dopamine, which affects the basal ganglia pathways and increases movement initiation. So too much dopamine can cause dyskinesias. Dyskinesias are like abnormal, unwanted, involuntary movements. There's a lot of them that I've listed in your notes, like dystonia, which is like muscle spasms, akathisia, which is like restlessness or strong compulsion to move, hemiballism, which is rapid ballistic flinging movements of the limbs, athetoid, which is like slow writhing movements. All these are the types of movements that are common with diseases that cause the brain to produce too much dopamine. So examples of these are Huntington's disease and Tourette syndrome. So both have kind of uncontrolled, jerky, different types of muscle movements because of the overproduction of dopamine. And it could be the too much dopamine, or it could be that the receptors are just too sensitive, and so they're overreacting to the amount of dopamine there. If the person has too little dopamine, then this would cause bradykinesia, which is like a slowness of movement. Parkinson's disease is the one we think of, where people have an underproduction of dopamine because some of the neurons within the substantia nigra have died. And so the symptoms include a slow movements, shuffling gait, freezing of gait. The movements are small, even though their brain is telling them to do big movements. It's really hard to start and initiate movements. They have often cogwheel rigidity. So as you're stretching them, it's like moving in like a cogwheel, like it's getting stuck in different segments. Peel rolling. So the tremors are typically kind of start with this peel rolling tremor. The doll face, they have very minimal expressions. They have postural instability where they get stiff and kind of get stuck in this kyphotic posture. And physical therapy can help. It can help increase their movement and their function. It can also help slow down the process a little bit. But the primary treatment is with drugs that focus on increasing dopamine levels. Cognitive and limbic circuits of the basal ganglia, these modify your activity of the prefrontal cortex and the cortical association areas. They're important for emotions, for memory, for focus, for attention, and they may cause issues with memory, concentration, or slowness of thought and or dementia. Schizophrenia and OCD also affect these areas, the cognitive and limbic circuits of the basal ganglia. Motor planning, so the supplementary motor area, stores motor memories and directs activity of the primary motor cortex. Damage to this area can cause apraxia, which is your inability to perform purposeful voluntary movements in the absence of a sensory or motor impairment. So nothing's wrong with the neurons. You're getting normal sensation. You're able to move normally. However, you're just not able to coordinate those movements into purposeful actions. That's apraxia. You have difficulty performing those. People with apraxia have difficulty performing routine tasks, even though those things are intact. All right, so that is it for us today. If you have questions, you let me know, and get out and move. All right, I'll see you in the next lecture.